to cause these problems in the first place? Well, if you were to look at a dentist's tooth preparation closely, you would notice that when the enamel is removed, it exposes the dentin. As a result, both open and short margins on a restoration allow external influences access to the dentin, which, as we now know, will negatively affect the pulp. Overextended margins and over-contoured crowns also cause problems because the tissue recedes from the crown at the margin, this time exposing the cementum, which again starts the process of destruction of soft and hard tissues. As I already said, adjacent to the cementum are the periodontal ligaments. These ligaments are attached to the cementum on one side and the bone of the alveolar socket on the other. This bone is called the lamina dura. Some important functions of periodontal ligaments include anchoring the tooth in the alveolar socket and providing shock absorption during vertical, protrusive, and lateral movements of the mandible. The shallow V-shaped pocket in the soft tissues surrounding the tooth is called the gingival sulcus. The depth of the gingival sulcus is measured with a periodontal probe. A good, healthy depth is about 2 millimeters. A gingival sulcus depth of 4 millimeters can often indicate a periodontal disease called gingivitis. Symptoms of gingivitis include inflammation and redness of the gums, as well as bleeding that occurs during brushing or flossing. As this disease progresses, loss of bone and periodontal ligaments can occur. At this stage, a gingival sulcus depth of 5 or 6 millimeters can be indicative of periodontitis. As we've already discussed, when left untreated, periodontal disease will lead to tooth loss. The loss of this tooth is actually the result of homeostasis. Homeostasis refers to the body's attempt to maintain harmony among all of its biological systems. So, for example, if there's a stress or strain in a part of the body, the stress will be made neutral over time through homeostasis. However, a homeostatic response is not necessarily a good thing for the patient. An example of this is what happens when we create an overextended margin. The body naturally wants to have 3 millimeters of space from the crest of the alveolar bone to the margin of the crown. In the case of a 2 millimeter overextended margin, the hard and soft tissues will attempt to recede 2 millimeters to recreate homeostatic balance. If enough bone structure is lost, it will lead to increased mobility of the tooth, increased sensitivity, and a higher incidence of tooth loss. Once the tooth is lost, a number of homeostatic responses occur. The most obvious is that the opposing tooth will slowly move out of its position in an attempt to find an occlusal stop. This will create a condition called supereruption, where the occluding surface of the tooth extends beyond the occlusal plane, limiting the range of masticatory movements. Supereruption also weakens the support structure of the tooth as it grows out of the socket. With less of the root in the bony socket, the tooth becomes looser and looser. Like falling dominoes, after enough protrusive and lateral excursive movements of the mandible, the loosened supererupted tooth will become the next victim of homeostasis. But homeostasis can also be used to create positive change in the oral environment. The best example of this is the orthodontic movement of teeth in order to enhance aesthetics or to improve function. When an orthodontic bracket is tightened, it puts continuous stress on the tooth that it's attached to, and that stress is passed on to the periodontal ligaments that attach the tooth to the adjacent bone. Each periodontal ligament is somewhat elastic, but of a fixed length. Therefore, when a tooth is moved distally, for example, the distal ligaments will be compressed, while the mesial ligaments become stretched. The stretched ligaments are under tension, and the homeostatic response is to build up the lamina dura so that the tension is relieved. On the other hand, when ligaments are under compression, the homeostatic response is to resorb the lamina dura in the direction the tooth is being moved, returning the compressed ligaments to their original length. These changes take a long time to complete, with the buildup of bone taking twice as long as bone resorption. So in orthodontics, homeostasis is being harnessed in a positive way to move a tooth from one position to another in order to improve aesthetics and restore occlusal function. In order to discuss a basic posterior setup, let's first talk about the natural dentition we find in the permanent dental arch. The permanent dental arch consists of a maxillary and a mandibular arch. Each of these arches includes 10 posterior teeth, that's 4 bicuspids, also referred to as premolars, and 6 molars. That means that on either side of a complete arch, there will be a first and second bicuspid and a first, second, and third molar. The most distal of the molars, the third molar, is often referred to as the wisdom tooth. The third molar is rarely as well developed as the second molar, and because of evolutionary changes, not everyone's permanent dentition includes third molars. In many situations, there is not enough room in the arch to accommodate the third molar, which can crowd the other dentition. In some cases, the third molar does not always erupt completely through the soft tissue, and this can be a cause of continuous infection. As a result, dentists will often remove it. The third molar usually has extremely short roots, and they may be fused together, appearing to be a single root. When compared to other teeth, these factors contribute to a third molar's poor crown-to-root ratio, and therefore the third molar is not considered strong or reliable enough to use dependably as an abutment in a large fixed bridge. Removable restorations, such as complete dentures, will never include this tooth, so you should not be too surprised when I tell you that the third molar is not included in a basic posterior setup. A basic posterior setup includes 8 teeth, that's 4 bicuspids and 4 molars. That means that on both sides of the complete arch, there will be a first and second bicuspid and a first and second molar. If it's necessary to restore a third molar, just copy the anatomy of the second molar. But keep in mind, third molars are about 10% smaller than second molars. We tend to think of teeth as being oriented vertically in the dental arch, but they are not. You know from our discussion of the curve of Wilson and the curve of Spee that the teeth in both arches are angles specific to the occlusal plane, with the maxillary teeth inclined buccally and the mandibular teeth inclined lingually. As fixed technicians, we don't work with the roots of the teeth. However, full or partial denture technicians that are recreating tissue should know that, in general, the root is angled with respect to the occlusal plane. Now, I want to describe a simplified version of a system that will help you to create a normal bite whenever possible. I'm talking about the Angles Classification System, the most popular orthodontic dental classification system around. In an Angles Class 1 relationship, the mesiobuccal cusp of the upper first molar occludes the mesiobuccal developmental groove of the lower first molar. This is considered a normal bite, where overjet is equal to overbite. Some of the older textbooks refer to this relationship condition as the key to occlusion. In an Angles Class 2 relationship, the mesiobuccal cusp of the upper first molar occludes mesial to the mesiobuccal developmental groove of the lower first molar. This malocclusion is considered a retrognathic bite, retrusion of the lower jaw. 2 divisions based on anterior positions further define this class. With Division 1, there is severe overjet. In Division 2, there is no overjet, and the upper centrals are posteriorly inclined relative to the laterals. In an Angles Class 3 relationship, the mesiobuccal cusp tips of the upper first molar occlude distally to the mesiobuccal developmental groove of the lower first molar. This is considered a prognathic bite, a malocclusion that is visible as a protrusion of the lower jaw anterior to the upper arch. So how can you use this knowledge in your daily work? Well, if the posterior teeth are missing, even in 2 opposing quadrants, placing the first molars in the Angles Class 1 relationship will help you to restore proper function to your restorations. But what if there are a number of teeth missing, among them the first molars? Well, here is some information about intraoral landmarks that will help you with bigger fixed restorations where more than one tooth is missing, and when the dentist has not provided placement information. The denture technicians already know these soft tissue landmarks and use them to place teeth where only soft tissue is present. You need to understand that the teeth in both the mandible and the maxilla are surrounded and supported by the alveolar process and its soft tissue covering. The alveolar process is part of the bony understructure, and it includes alveoli, pockets into which the teeth fit. Each pocket, or alveolus, contains ligaments that keep the tooth in place. When you look at the soft tissue ridge that is visible on an edentulous arch, what you actually see is the shape of the bone that lies just beneath the 1 to 3 millimeters of soft tissue. The skeletal portion of this visible ridge is called the alveolar ridge. As dental technicians, we do not work on this skeletal portion of the ridge. Instead, we place our restorations on top of the soft tissue ridge. That's why we call it the residual ridge. It's worth noting that we call it a residual ridge whether or not teeth are present. The incisive papilla is a small teardrop-shaped elevation of soft tissue centered on the palatal midline, just lingual to the crest of the residual ridge. The raphe palatine is a thin, elevated area of soft tissue centered on the palate, extending in a posterior direction from the incisive papilla along the center of the palate. The rugae are tissue folds that create the irregular, wrinkled surface on the anterior half of the palate. The labial vestibule is the space between the residual ridge and the lips. The retromolar pads are elevations that are sometimes pear-shaped, soft tissue landmarks located at the posterior termination of the mandibular residual ridge. In the anterior segment, we established anterior teeth arrangements based on the positions of two imaginary lines. The midline, a vertical line which runs between the upper centrals, bisecting the face into left and right halves, and the horizontal axis, a line identifying the position of the upper anterior incisal edges that is at a right angle to the midline. This method works well just as long as there is plenty of remaining dentition and as long as the face is symmetrical. That's because nature does a good job of placing the centrals on the midline. But what if the incisals are missing and the dentist didn't identify a midline on the impression or the RX? Well, it turns out that an upper solid model contains intraoral landmarks that can be used to help identify the midline. There is an imaginary line that follows the raphe palatine and goes across past the incisive papilla to the residual ridge. Where this line crosses the residual ridge, imagine a vertical line. This is your midline. The upper centrals are then placed on the residual ridge on either side of the midline. On average, there should be approximately 7 millimeters from the middle of the incisive papilla to the facial surface of the upper centrals. It's clear that for aesthetic reasons, the upper centrals need to be aligned with the middle of the face, much more so than do lower centrals. Upper centrals are the eye catchers, and if they are symmetrical to the face, everything else will look fine. So what we do is use the midline to establish the upper centrals. Any offsetting or twisting of the lower anteriors will usually be concealed by the lower lip and the upper anteriors anyway. In cases where you have to replace quite a few lower anteriors, focus on bilateral symmetry instead of trying to make the midlines line up. As you recall from the anterior section of this video, the horizontal axis corresponds to the incisal lengths of the upper centrals and canines. But what if you don't have any of this information? Here's what you do. On the maxillary arch, locate the deepest point of the labial vestibule and measure down 22 millimeters. This gives you the approximate incisal position of your upper centrals and canines. And because we're trying to establish angles class 1 bite, for more accuracy, make the overjet equal to the overbite. You can do the same thing on the mandibular arch. Locate the deepest point of the labial vestibule and measure up 18 millimeters. This gives you the approximate incisal position of your lower anteriors, which are all about the same length. Once again, to fine-tune the incisal positions, make the overjet equal to the overbite. Once the incisal edges on the lower arch have been determined, imagine another line connecting the upper third of the retromolar pads. Connect these two lines and you establish a plane. Now, imagine a sphere with a 4-inch radius. This is the sphere of Monson, or Monson sphere, and is a combination of the curve of Spee and curve of Wilson. Applying the curves of the Monson sphere to your imagined plane creates the occlusal plane for the lower arch. The occlusal plane helps you to establish the overall incisal and occlusal surfaces of all teeth in the arch. There are also landmarks on the upper palate that provide clues for the proper placement of canines when lots of teeth are missing. Posterior to the incisive papilla, the first pair of long rugae point to positions on the residual ridge where the canines should go. On average, the most lingual aspect of the canines should be about 2 millimeters away from the ends of these long rugae. Place the lower canines so they occlude between the upper laterals and canines. Next, Imagine a line along the mandibular residual ridge, from the mesial incisal edge of the lower canine to the lingual side of the retromolar pad. Line up the lingual cusps of the lower posteriors along this line. Fine-tune this arrangement by lining up the central developmental grooves of each tooth so they form a straight line. Finally, make sure to adjust the lower posteriors to correct for the curve of Wilson and the curve of Spee. The distal marginal ridge of the lower second molar should not come above the highest portion of the retromolar pad. Now, the upper posteriors can be placed along the maxillary residual ridge based on the positions of the lower posteriors, making sure they reflect an angled class 1 relationship. Again, consider both the curve of Spee and the curve of Wilson when making any final adjustments to the upper posteriors. Remember, we always prefer that you get your placement information from the dentist. But in cases where this information is lacking, intraoral landmarks and occlusal relationships can help us to approximate the locations of teeth. In this section, I want to talk about the occlusal surfaces of posterior teeth. But I need to make one thing clear from the start. If I say that I want you to make all teeth look exactly like natural teeth, you need to realize that natural dentition is not nearly as standardized as we would like to think. There are an infinite number of variations of natural teeth. Also, what a restoration will look like is very subjective and depends in large part on the perceptions and technical abilities of the technician. So I'm not going to tell you how to create dental morphology that tries to mimic nature. Instead, I'm going to tell you about my stylized posterior anatomy that I've established as a laboratory standard. I realize that you won't find this information in any textbook or in natural dentition for that matter, but it works. And I want everyone at Glidewell Laboratories to follow my guidelines for stylization so that you can consistently create restorations with great aesthetics that function properly in the mouth. Our stylized anatomy gives parameters to the technician and quality control personnel that can be easily communicated so that everyone is on the same page. It also guarantees that every time a dentist opens up a case from Glidewell Laboratories, those restorations will have the same stylized morphology as previous cases. That's very reassuring to them and will help us to keep them as customers. Just like natural anterior teeth, natural posterior teeth are created by the formation of developmental lobes. An upper second molar, for example, is made from 4 lobes, and a lower first molar is made from 5 lobes. Where adjacent lobes meet, a developmental groove is formed. Developmental grooves are narrow V-shaped trenches in the anatomical crown. Depending on how many lobes make up the tooth, there are different developmental grooves that can be identified. In our 5-lobed first molar, there is a mesiobuccal developmental groove, a distobuccal developmental groove, and a lingual developmental groove. The central developmental groove goes across the occlusal table from the mesial to the distal, dividing the tooth into buccal and lingual sections. This major landmark can be identified in every posterior tooth. The central developmental groove can be used to determine proper lingual buccal alignment in posteriors. Sometimes, you may hear a developmental groove being referred to as a fissure. However, we typically reserve the word fissure to describe the unfinished fusion of enamel at the junction of adjacent developmental lobes. On close inspection, a fissure makes the central developmental groove appear deeper because of the steepness of the fissure walls. Another feature found on the occlusal table is the fossa. These are areas of irregular depressions along the central developmental groove. They're definitely areas and not points. Depending on the tooth, the occlusal table can have up to 5 fossa. In posteriors, the most recognizable are the central fossa, found only on molars and lower second bicuspids, and the triangular fossa, one at the mesial and one at the distal. A pit, on the other hand, is a deep and steep pinpoint depression. It is not an area, it's a point. The term pit should not be used interchangeably with fossa. Pits are found at the intersection or termination of developmental grooves, and just like fissures are the result of an incomplete fusing of the enamel. And now, let's discuss supplemental grooves. Supplemental grooves are shallow little creases in the tops of the developmental lobes. If you look at the dental anatomy of many of our technicians' restorations, the supplemental grooves are very, very deep. But supplemental grooves shouldn't be that deep because they are not formed by the joining of developmental lobes. They are supplemental to the developmental grooves and should be subtle in comparison. Supplemental grooves start out as very broad, shallow areas around the cusp tips, but they do not extend outside of the occlusal table. As supplemental grooves work their way down towards the central fossa, they get narrower and a little deeper and meet the developmental grooves at about a 45-degree angle. This is part of my stylized anatomy. Even though this angle will vary in natural dentition, this 45-degree angle is something I want your supplemental grooves to have. Let me sidetrack a bit here and talk to you about Pitt & Fisher sealants. You see, even though we're in the business of making teeth, people need to take care of the teeth they do have. And Pitt & Fisher sealant is one real good way to do just that. Your kids get their permanent posterior teeth during a time when brushing is not their favorite thing to do, and they lack the hand-eye coordination to get the brush where it's needed. To help protect their teeth at this time, you need to keep food particles and sugars out of the pits and fissures. As I have mentioned, these are areas with thin or unfused enamel, and they become traps where occlusal decay begins. A solution to this problem is Pitt & Fisher sealant, a flowable composite that the dentist bonds into place around 6 years of age. This composite fills in and seals the fissures in the developmental grooves and the pits in the fossa. The research shows that it really works for protecting occlusal surfaces, but you still need fluoridated water to protect the interproximal and smooth surfaces on all teeth. With Pitt & Fisher sealants, fluoridated water, and proper brushing and flossing, you can just forget about cavities and crowns for your kids for years and years. Now let's talk about ridges, another important feature of occlusal surfaces and of my stylized occlusal anatomy. When we create supplemental grooves, ridges are formed too, in this case triangular ridges. We don't contour the ridges. What we really shape are the supplemental grooves, and in the process, ridges are formed. Triangular ridges are natural features and should never be straight lines, and should be angled about 45 degrees in relation to the central developmental groove. Triangular ridges connect cusp tips to the developmental grooves and are given the name triangular ridges because the inclined slopes on each side of the ridge look like triangles. What I don't want to see are triangular ridges on molars that are set directly across from each other, with the supplemental grooves at 90 degrees. These tend to look like railroad tracks on the occlusal surface. As you can see, they just don't look right. On the other hand, transverse ridges are created when buccal and lingual ridges connect perpendicular to the central developmental groove. Sometimes this ridge is nearly uninterrupted as it crosses the occlusal surface. In other cases, it's clearly divided at the central developmental groove. Transverse ridges can be found on both upper bicuspids and on lower first bicuspids. Like a transverse ridge, an oblique ridge crosses the central developmental groove, but it crosses diagonally instead of at a 90-degree angle, working its way across the occlusal surface from the mesiolingual cusp to the distal buccal cusp. A clearly defined example of an oblique ridge can be found on upper first molars. The perimeter of the occlusal table is made up of a series of ridges. The most important are the mesial and distal marginal ridges, which form the rounded mesial and distal borders of the occlusal table. These ridges form the borders of the central developmental grooves. There are a number of anatomical differences among posterior teeth. Among them, the number of cusps and the occlusal shape. In general, a bicuspid has 2 cusps. That's why they call it a bicuspid in the first place. The only bicuspid with more than 2 cusps is the lower second bicuspid. It has 3 cusps. The lower first bicuspid has 2 cusps, but the lingual cusp has no occlusal function. That is, it doesn't come into occlusal contact with anything. In general, there'll be either 4 or 5 cusps on a molar. For instance, in the lower arch, the first molar normally has 5 cusps, while the second and third molars have only 4 cusps. In the upper arch, the second molar always has 4 cusps. The upper first molar is unique. It has 4 cusps and sometimes 5. The 5th cusp has relatively little or no function, is located on the mesiopalatal portion of the tooth. It is called the cusp of Carabelli and is named after Professor George C. Carabelli of Vienna, Austria. The cusp of Carabelli is this little nonsensical thing and in many cases will only be represented by a slight increase in elevation from the gingival to the occlusal. It's often left out of restorations completely because it does not usually affect the function of the tooth. It's possible for the cusp of Carabelli to be functional, but only if it's big enough. You'll occasionally see a large one wrapped all the way around the mesiopalatal cusp. When it's this big, you will see it in function with the opposing dentition. The cusp of Carabelli can be unilateral. That is, it may exist only on one side of the arch, or it can be bilateral, existing on both sides of the arch. The upper third molar is also quite unique. This tooth usually has 3 cusps, but sometimes it has 4, and it's not unheard of for an upper third molar to have 5 cusps. There are 6 basic tooth shapes as seen from the occlusal. These shapes are based on the number and location of the cusp. Knowledge of these simplified shapes will make it easier for you to identify specific posterior teeth. These basic shapes are identified as circular, elliptical, triangular, trapezoidal, rectangular, and rhomboidal. The upper bicuspids are elliptical. The lower bicuspids are circular. The upper first and second molars are rhomboidal. An upper third molar with 3 cusps will be triangular, but if there are 4 cusps, it will be rhomboidal. With 5 cusps, this tooth becomes something of a distorted rhomboid on the verge of becoming round. The lower first molar is trapezoidal due to the 3 cusps on the buccal and the 2 cusps on the lingual. The second and third molars in the lower arch are both rectangular because of the 4 more or less equally sized cusps. It doesn't matter whether the patient is young or old, these shapes remain basically the same over a lifetime. Another important aspect of the occlusal surface is the relationship of the occlusal table's buccal lingual width to the tooth's buccal lingual height of contour. This relationship is given as a ratio that we call the occlusal ratio. On natural uppers, the occlusal table represents about 55% of the tooth's buccal lingual height of contour, yielding an occlusal ratio of about 5 to 9. You'll notice the occlusal table on uppers is positioned closer to the buccal than it is to the lingual, placing the stamp cusp close to the long axis of the tooth. The long axis is the center line that passes through the coronal aspect to the root tip. On the other hand, the occlusal table on natural lowers is smaller and represents about 45% of the tooth's buccal lingual height of contour, or a ratio of about 4 to 9. The occlusal table on lowers is positioned closer to the lingual than it is to the buccal, again placing the stamp cusp close to the long axis of the tooth. Unfortunately, lab technicians tend to make crowns and ponics too wide when compared to natural dentition. Because when we hear the occlusal table is almost the same diameter as the buccal lingual height of contour, it places the chewing surface too close to the cheek and tongue and increases the occurrence of cheek and tongue biting. Another mistake occurs when technicians make the occlusal table too narrow and place it right in the middle of the tooth. This decreases the size of the chewing surface and makes it difficult for the cheeks and tongue to keep the food in the chewing cycle. Both of these mistakes create forces that do not align with the long axis of either tooth. This leads to an unhealthy rocking of the tooth, and the longer a tooth rocks, the more likely that its health will be compromised. You must also keep in mind that we are often presented with periodontally compromised dentition. Therefore, as part of my stylized anatomy, we make the occlusal ratio 5 to 9 on both uppers and lowers, which means that the occlusal table will be a little more than half the size of the tooth's buccal lingual height of contour. This is true for ponics as well, although with ponics, the buccal lingual width should be about 15% smaller than the original tooth form. By using a 5 to 9 occlusal ratio for all restorations, the added stability will help our patients keep their teeth for a long period of time. Now, I'm going to cover some aspects of the way cusps function. And to do that, I want to start by introducing stamp and shear cusps. The lingual cusps on lowers and the buccal cusps on uppers are called shear cusps. The occlusal contacts on shear cusps are within their occlusal tables. The buccal cusps on lowers and the palatal cusp on uppers are called stamp cusps. Stamp cusps have contacts not only within their occlusal table, but also outside of their occlusal tables, specifically on the buccal aspect of the lower stamp cusp and the lingual aspect of the upper stamp cusp. Shear cusps break food into small pieces, while at the same time, stamp cusps grind the food into even smaller, easier-to-swallow pieces, much like a mortar and pestle. In conjunction with the tongue and cheek, shear cusps also help to keep food on the occlusal table. Because the tip of a shear cusp is unopposed, technicians tend to make it too long. In doing so, they disregard the curve of Wilson and create flat-planed occlusion. Remember flat-planed occlusion? This is one of the most common violations of tooth morphology. Making a shear cusp too long causes occlusal interferences. That is, as the jaws are moved in lateral excursions, these long shear cusps receive excessive lateral stresses from the opposing dentition, damaging the periodontal tissue and lamina dura. Remember, posterior teeth can withstand forces that are along the long axis of the tooth, but will be damaged by lateral forces. On the other hand, stamp cusps are never too long because they always have opposing dentition that limits their dimension. If stamp cusp is too long, you won't even be able to close an articulated model. On lower posteriors, the portion of the tooth with the stamp cusp represents about 60% of the tooth's occlusal surface, while the portion with the shear cusp represents about 40%. On uppers, however, the percentages are closer to 55% for the stamp cusp and 45% for the shear cusp. As you can see on both uppers and lowers, the stamp cusps take up more of the occlusal surfaces than shear cusps, and therefore they also exert the most force. If you want to create teeth that are balanced and stable when they occlude with the opposing dentition, you need to understand the concept of tripodized occlusion. Tripodized occlusion is a cusp-fossa relationship where the stamp cusp has 3 points of contact with the opposing fossa. When each cusp and fossa is tripodized, it creates a solid, balanced occlusion by directing masticatory forces along the long axis of the tooth. It's just like with a tripod. If only 2 legs are down, it's not balanced. But as soon as you put the third leg down, it is balanced. You should also be aware that the 3 contact points of the stamp cusp are not going to be in the pit of the fossa, nor at the tip of the cusp. In fact, the tip of the cusp and the pit in the fossa never come into contact. It doesn't happen in natural dentition, and it shouldn't happen on your restorations. What you really want is to spread out the area of impact onto the surrounding ridges. The contact points are in the fossa, not the pit. In fact, they're located about halfway down, or 1.5 to 2 millimeters away from the pit. And on the opposing cusp, the contact points are going to be located about halfway down, or 1.5 to 2 millimeters away from the cusp tip. Now let's say we eliminate one of these 3 occlusal contacts. Without the cusp hitting in that third spot, what's the worst that could happen? Well, because that stamp cusp is only hitting in 2 spots every time the patient bites down, these teeth will be flexed and forced out of their positions. If this continues, the periodontium will begin to recede. Ultimately, the flexing will cause microcracks, called abfractions, in the buccal surface of the cementum, apical to the CEJ. Over time, the cementum in this area will be eroded and will appear as a crescent-shaped lesion at the CEJ that is painfully sensitive to the patient. This is a big problem because fillings in this area tend to pop out as the tooth continues to flex. To finish this section on occlusal surfaces, I want to talk about what happens when there is 1 millimeter or less of occlusal clearance available for the restoration. With so little space, there can only be a very thin ceramic coverage. A restoration made this way is going to look just awful because the substructure will show through the porcelain. Also, once it's in the mouth, there is a good chance the patient will fracture the thin porcelain. In order to deal with this problem, Some dentists may request that a very small area of metal be placed where the opposing dentition hits. This is called a metal island. However, in contrast to the surrounding porcelain, the metal will be accentuated, compromising the restoration's aesthetics. The better aesthetic choice when dealing with a thin restoration is to make a full metal occlusal. These are occlusal surfaces that are made in metal instead of porcelain. A full metal occlusal will enhance the restoration's durability. So, when should the buccal cusp be included or excluded as part of the metal structure on a metal occlusal? The upper buccal cusps are visible in the buccal corridor, so for aesthetic reasons, we always exclude the buccal third of the upper buccal cusp from the metal structure. That's because porcelain facings will always look better without metal showing at the incisal. With lowers, however, the aesthetics aren't really a concern because once the bite is closed, you can't see the buccal cusp. Therefore, for purely functional reasons, the buccal cusps on lowers are included in the metal substructure. Lower buccal cusps are stamp cusps, and they put more force on the opposing than an upper buccal cusp. Therefore, for strength and fracture prevention, the porcelain metal junction should never be placed in areas of a direct occlusal contact. Instead, they must be cervical to the occlusal contact. The porcelain metal junction of the metal occlusal must follow the anatomy and should never be a straight line. Also, the porcelain metal junction must be made at a right angle to the outer contour of the finished restoration. Porcelain metal junctions should never be contoured in such a way that the porcelain has to be packed underneath the metal edge, because the metal will bend, breaking its bond and fracturing the ceramic. Now that we've covered the basic concepts related to occlusal surfaces, I want to talk about contouring and its effect on periodontal health. You should know that on restorations, both incorrect contouring and incorrect margins accelerate tooth loss by encouraging periodontal disease. So we really need to understand contouring and how it relates to marginal accuracy to avoid these negative effects. After all, our job is to help the dentist restore the patient's mouth to a healthier condition, not to cause damage. The problems associated with over-contouring and marginal accuracy are especially problematic because in the early stages,